Welcome everyone. This is Patricia from the International Hospital Federation. Thank you for joining us in our webinar, A Better Model to Predict in-Hospital Mortality. This webinar is being presented by Dr. Rowan Cattell, Chief Data Scientist of the Health Roundtable. It is with pleasure that I now introduce our webinar presenter. Dr. Rowan Cattell has a background in mathematics, software development, and data analysis. He has worked with the Health Roundtable since 2010 when he was recently appointed Chief Data Scientist. His work includes developing predictive modeling for a range of hospital benchmarking activities, including measurement of in-hospital mortality. The Health Roundtable is a membership-based organization consisting of 178 mostly public hospitals from 93 health services across Australia and New Zealand. Rowan, welcome and thank you for joining us today. We look forward to learning about the model that the Health Roundtable has developed.
Great, thanks Patricia, and thanks to the IHF for hosting and inviting me to speak. I'm going to talk about predictive modelling of in-hospital mortality, mostly from the context of reporting and tracking of mortality rates. At least that's the background from where the Health Roundtable has come into this. However, I think the underlying modelling, which is mostly what I'm going to be talking about, it should be of interest outside of that space as well. I'll start with a little bit of background about the Health Roundtable, who we are. So we're based in Australia and New Zealand, and we're a not-for-profit membership-based organisation. We've got about 177 mostly public hospitals in Australia and New Zealand that are our members, and we produce benchmarking reports for those hospitals, and we also run improvement groups for our members. If you're interested in more information about the Health Roundtable, you can go to our website, www.healthroundtable.org. And there's a contact form there. If you have any questions beyond the presentation today, please contact us and feel free to ask. So just a bit of context before we get into talking about the actual modelling side of this. So the Health Roundtable reports on mortality rates to its members. Most of the reporting we do is around benchmarking. We're very much not an accountability organisation. We're not the government, so we're very much about innovation, benchmarking for innovation, and also we do some amount of screening for outliers for our members, and so that's a key part of what our mortality reporting is about. We produce funnel plots, for example, to give feedback to our members so that they know where they are statistical outliers with respect to mortality rates. We produce trends. We have a variety of tools both online and also in static PDF type reports that are produced for our members. We produce comparisons to other facilities. We often produce distributions of results such as funnel plots, aggregate level data at a hospital level, and we also break it down into smaller groups. For example, we might monitor mortality rates by principal diagnosis. So what are the ways that we might present mortality rates for in-hospital mortality? The most basic, of course, is a crude rate where you just take a number of deaths in a patient cohort and divide it by the number of episodes. So here, by episode, I mean an admission, a hospital admission, essentially. So a number of limitations of doing this, obviously, you know, although it can be useful for looking at a single hospital's rate over time or a cohort of patients over time, it's not very useful for comparing between facilities, and it's not very useful if there's a change in patient cohort. It's difficult to separate out what might change a crude rate. So some of the other ways that we might look at it, we have standardised mortality ratios, or SMRs, and this is deaths divided by expected deaths. This expected deaths is an expected number of deaths, a very important distinction here, certainly one that causes a lot of confusion because of the language. Here we're talking about an expected number as in an expected value, a statistical expected value, an expected number of deaths. The confusion often arises because people confuse this with the notion of, in classification, of an expected death, for example. So certainly what we're talking about here is a statistical expectation, an expected number of deaths, and we'll be talking a lot more about that concept through this talk. The other way we might display mortality rates is with predicted intervals. So this would be deaths divided by episodes, so like a crude rate, but then it's compared to some interval around an expected mortality rate. And this is quite a good way of displaying mortality rates, because you get to see both the crude rate and you also get away from the problem of showing a point estimate. And we all know that SMRs can be misused, especially when you present them as point estimates. People have a tendency to want to stick them in league tables and so on. It causes a lot of controversy. So predicted intervals are quite a good way of displaying mortality rates. The main thing to note is that both standardised mortality ratios and predicted intervals require some way of calculating an expected number of deaths. So how do we calculate an expected number of deaths? Well, it's essentially a sum of the probabilities of death of all the episodes in a cohort of patients. So as I said before, a statistical expectation, a sum of the probabilities. And the point of the predictive modelling exercise, of course, is to model in such a way that that probability is high. It gives us a good level of discrimination. So when we talk about a probability of death for an episode, what do we actually mean? Well, we're talking about in-hospital deaths. So we mean the probability that a patient will die during the episode. Sometimes we might also talk about death in stay. In Australia, a hospital stay can consist of multiple episodes. So we just make that distinction where we might track an episode being the first episode in the stay, but we're still interested in whether the patient may have died at some point during the stay, even if they were moved into a separate episode. One thing that's worth noting is, from my experience of talking to doctors about mortality rates, doctors often think of the probability of dying in terms of a patient dying in the next few months or in the next year, and they're often surprised when they see probabilities of death generated by these kinds of models, because they're a lot lower than doctors will expect. The probabilities we're talking about are the probability that a patient would die in that exact episode during that stay in hospital. So first I just want to review some of the existing models before I talk about some of the innovations that we've developed for our new modelling. So the most prominent models, in Australia have come out of this reporting environment. So they tend to be the ones where people have generated hospital standardised mortality ratios either at a national level or at a jurisdiction level in Australia and New Zealand. So I'll just talk about 4 of the most prominent models that have been used here. And keep in mind, if you're not a fan of HSMRs or SMRs in general, especially of HSMRs, they're very controversial. So keep in mind that the underlying predictive model can be seen as separate to that, and its utility can certainly go beyond generation of HSMRs. So there's the Chaboy HSMR. This is the core hospital-based outcome indicators HSMR that was developed by the Australian Commission on Safety and Quality in Healthcare, and that's used at a national level in Australia. There's a New Zealand Ministry of Health hospital standardised mortality ratio, which is based on the Scottish model. There's a legacy Health Roundtable HSMR, which we used up until 2016. And there's the Dr. Foster HSMR, which should be more familiar to many of the international attendees today. So Dr. Foster also provided HSMRs to the Victorian government in Australia, and I think will be most familiar with our international audience because of their extensive use in the UK. So what's common in all of these models? They're all logistic regression models, and they all look at age, sex, was the admission an emergency admission, was it an acute transfer, so a transfer from another acute hospital. The Charlson Comorbidity Index is common to all of these models as well. The Charlson Comorbidity Index is a group of comorbidities that are scored, and each patient, each episode gets a score. Then each of these models has some variation around utilising principal diagnosis. So usually it's a 3-letter principal diagnosis or some risk group based on the principal diagnosis. There are also a bunch of other factors that are used in specific models, some of which, well, all of which I'm not going to discuss today that apply specifically to a couple of the models. So what's the problem, and what's our motivation for coming up with something different? Okay, so let's consider a model based on principal diagnosis. What we've got on the screen at the moment is an example of a patient episode. The diagnosis listed in position 1 is the principal diagnosis. The rest of the diagnoses are then listed after that. In Australia, diagnoses are also either noted as arising during an episode of care or otherwise presumed to have been present on admission, and we're going to make use of that coding called the onset flag in Australia. It may be available to differing degrees in different countries around the world. Mostly we'll just be interested in diagnoses that were present on admission, or which we assume to have been present on admission because they weren't noted as arising during the episode of care. So what's the problem with just looking at the principal diagnosis and the Charlson score in order to assess the risk of a patient? Well, at best these models look only at the first 3 letters of the principal diagnosis. In this case, that would be S06 in ICD-10 codes, which is intracranial injury. This could be a wide range of conditions and certainly doesn't give us as much information as the full 5-letter code. But even more importantly, these models ignore critical information which could be used to make a better prediction of the probability of death for this patient. In this case, the model that just looks at principal diagnosis and Charlson score would ignore the fact this patient has already had a cardiac arrest before arriving at the hospital and has suffered brain damage. So worth noting that the Charlson score is fairly limited in what it covers. Certainly it's not going to cover trauma, multiple trauma. It's just a list of chronic conditions. So what would a better model look like? Well, we could use the full length of the ICD-10 code. We don't want to throw away information. We should assess risk based on all the diagnoses that were present on admission. And we should make particular use of the diagnosis of maximum risk. Which of all of these diagnoses was the one that was most likely to contribute to a patient's death? So in 2016, we released the first version of a new predictive mortality model, which we've used as the underlying model for our mortality indicators that we present to our members. We've called this the AP-MortR model, which stands for Admitted Patient Mortality Risk. So in reality, it's 3 different logistic regression models, one for each of 3 age groups. So we have an adult model for patients 17 plus, there's a pediatric model for patients 28 days up to 16 years, and there's a neonatal model for 28 days and under. And what distinguishes these models is that they introduce 2 new continuous variables to replace or possibly supplement the use of the principal diagnosis and the Charlson score. And we call these MRS for maximum risk score and SRS for secondary risk score. And we make use of these continuous variables in the logistic regression model. So in order to explain what these two variables are, we need to take a step back for a moment. If we consider the ICD-10 hierarchy, what we want to do is create a reference table that for every code in that hierarchy, we have a risk score. This risk score is marginal with respect to age and so on, so it's just a crude risk score. Naively, we might take a crude mortality rate for the code in our reference data. So here's an example, what we might do. So in a one-year reference set of the Health Roundtable, code A047 is coded in 10,280 episodes of care, of which 499 were deaths, and simplistically we could just take 499 divided by 10,280 to get 0.0485 as our risk score for that diagnosis. I said this was a little naive and it's not actually what we do, but I want to just think about it in that way for now while we explain what those two new scores are, and then we'll come back to talk about some of the subtleties of how we really calculate that risk score. So the two new scores, the maximum risk score is the maximum of the diagnosis risk scores that we generated. So we just think now that we have a reference table, so these risk scores that we've generated in that reference table are at a diagnosis level across all of our reference database. We're now talking about scores that are generated per episode, and these are the scores that are actually used in our logistic regression model. So the maximum risk score is the maximum of the diagnosis risk scores. Fairly straightforward. The secondary risk score is a calculation based on all of the other diagnosis risk scores combined. Worth noting here that before we do these calculations, we reduce the set of diagnoses a little bit. So if there are multiple diagnoses that were present on admission and that were all in the same ICD-10 block, we only consider the one that has the highest risk. We also ignore some of the actually all of the late alphabet codes from the U codes onwards in the ICD-10 hierarchy. So maximum risk score, as noted, if once mathematically very simple, so if once we've made that reduction of diagnoses for an episode, if there aren't any, then we set that score to 0. Otherwise, it's the maximum risk score of the diagnoses that are remaining. Secondary risk score is a little more complex. So if we consider turn the risk scores into survival scores, so we take 1 minus the risk score, and then we take the product of those scores, just for the remaining diagnoses that weren't used as the diagnosis of maximum risk. We take the product of those, so for example, if the first diagnosis had a survival rate in the reference table of, say, 99%, and the second one had 98.5%, then we would multiply those together, and then we'd take the next diagnosis in the list and multiply that. And as you go through that, the survival score comes down a little bit, and then we take 1 minus that score to get our final risk score for the secondary risk score. Some people might note that this is similar to the calculation of the ICISS for people who are familiar with this score that's used in the context of trauma. And there's a paper by Rutledge et al. In 1996 which describes that. There are going to be some differences, though, as to how we actually calculate the risk scores, which differentiate from the way that the ICISS is done. So we have a paper that's available from the Health Roundtable. If people are interested in the details, I don't want to get bogged down in the mathematical details in this brief talk, but certainly we can make this available to people. So if you want to get in touch with us, you can either do that through our website, and also Patricia later will be taking a poll on who would like us to contact you. If you are interested in the detailed paper, we can provide that to you. So in brief, what's the problem with using the raw crude mortality rate? Well, the problem is that in the entire list of ICD-10 codes, sooner or later you run across codes that have very little data and you have very little capacity to make accurate estimates from that. So how are we going to get around that problem? And I'm just going to talk briefly at a very high level about the approach that we took. So here's a motivating example. Let's suppose we want to look at code J11.8. This is influenza with other manifestations, virus not identified. In our database we have 18 episodes, 0 deaths. So the crude rate here is 0%. Can we do better than this in terms of an estimate for our risk score? So the approach that other models would take is to say, well, you just look at the first 3 letters of the diagnosis and make do with that. You lose, of course, the 4-letter differentiation there for code J11.0, but maybe that's good enough. Let's look at another example. What about codes for intracerebral hemorrhage? Here the full length of the code is really important. It really distinguishes a different survival chance between the different codes at the 4-letter level of the ICD-10 code. So how can we generate a model that's able to use the full 4 letters when there's enough data available, but that falls back to making estimates based on codes that are nearby in the hierarchy when there isn't enough data available? Here's a very general, high-level view of our risk score algorithm and how it works. We take a weighted Bayesian approach to traversing the hierarchy of ICD-10 codes. Essentially, we look at J11.8 and we look at the likelihood of drawing J11.8 from the same distribution as the rest of J11. We use that to generate a weight, W, and we take the rest of J11 as a prior distribution but weighted by W. We generate a posterior distribution and take the maximum likelihood estimate as our risk score. The final algorithm that we use is a little bit more complex than that because it traverses the hierarchy from the top down and in each case uses the posterior at each stage as the prior for the next. But that's the general idea. Essentially using as much information as we have available when we can. So here's what the top 10 ICD-10 codes look like in this risk score. At the top, sudden cardiac death, so described. You might wonder why this doesn't get a score of 1. Interestingly, there are some episodes in our database that are recorded as having survived. Only a couple. You can see that the rest of these codes are what you might expect to come out at the top of a set of risk scores. This gives you an idea of what the full reference table might look like of all of the ICD-10 codes, each with a risk score next to it. So what does the AP-MortR model look like? Well, we use age, sex, emergency admission and transfer like the other models that I described before. We then use the MRS, the maximum risk score. We use the SRS as the secondary risk score as continuous variables in the logistic regression model. And we also include the MRG, the maximum risk group. That is a group into which the diagnosis of maximum risk falls. This is a broad clinical group similar to the way that we might group principal diagnoses in the ICD-10 hierarchy. The dependent variable that we use is death in stay, which I mentioned earlier. And the logistic regressions run on a multi-year data set of acute care type episodes, and it includes most two-way interactions in the model. So this is a broad description of the model, but how do we evaluate it? How do we decide if this is a better model than the one that just looks at principal diagnosis? So to evaluate this, we looked at our model, we looked at our legacy Health Roundtable model, and we also looked at the Chaboy model that's used nationally here in Australia. The reason we chose these models is because we had the methodology to hand, and we already generate these models in-house. It would be great to also look at some of the other models that I mentioned before, and that's some work for the future. However, it's probably worth noting that those other models aren't significantly different to these ones. So all models were tested on the exact same data set with the same exclusions, and this is a data set that was independent of the data set that was used to develop the model. We used 10-fold cross-validation on each model. So how do we compare models? Well, the two most important factors to examine in the performance of a predictive model are the calibration of the model and the discrimination of the model. Here's a chart showing comparison of calibration. It's worth noting that the Chaboy model and the legacy HRT model really have very few predictions above around 50%. In fact, they probably have very few predictions above about 20%. So of course these models tend to fall away in terms of their calibration with not only small numbers but a very small amount of volume that affects the overall model in those upper areas of prediction. Worth noting though that the AP-MortR model is well calibrated across the full range, including predictions very close to 100%. Discrimination has been described as, the willingness of a model to go out on a limb. So how willing is your model to say, yep, this patient is going to die? Well, here we have a chart showing all the deaths in the validation set. We have estimated probability of death along the horizontal axis, and the vertical axis is the number of deaths. So the AP-MortR model is the blue line, and as you can see, for the patients who actually died, the AP-MortR model was much more likely to assign a high level of risk to that patient. The Chaboy model, for example, falls off much earlier and is very reluctant to give any predictions above around 30 or 40%. The legacy HRT model goes a little bit further, but still doesn't come anywhere near the AP-MortR model in terms of discrimination. And you can see that blue line, there continue to be sizable numbers of predictions in the very high range, including up towards 100%. The flip side of that is to look at survivals. And here we see that the AP-MortR model also is much more likely to assign a very low probability of death to survivals. Here's an example of the kind of output that we get from our model. One of the benefits of this kind of model is that it's very transparent. So unlike, for example, machine learning models, which tend to be a black box, there's a very clear process by which risks have been assigned to diagnoses. We can feed this back in terms of patient records to our members so that they can see very transparently how an estimate of risk was arrived at. This also lends to possible uses outside of creation of expected numbers of deaths and reporting potential uses in classification, for example. So here you can see where we've marked on a patient record the diagnosis of maximum risk, which in this case is pneumonitis. Keep in mind that the old models would have just looked at the principal diagnosis and ignored all of those other codes. The onset flag here can also be seen in the patient record. So we can see the ones with onset 2 are the ones that were present on admission, and the ones with a 1 were noted as arising during the episode of care and are ignored by our model. So for this particular patient, the maximum risk score was 0.22, the secondary risk score was 0.5, And we determined a mortality risk of 18.52% for this patient to die during the episode. That's really very high. The old mortality risk in our old model was just 0.74%. So to summarise, we've introduced two new continuous variables, the MRS and the SRS. The model that uses these has better calibration and much better discrimination than competing models that we tested against. We're doing further work to find the right role for principal diagnosis in these models. Our version 1.2 of the AP-MortR reintroduces some aspects of principal diagnosis. We probably went too far in throwing out principal diagnosis in the first instance. And so we're looking at how groups of principal diagnoses can also be incorporated into the model and work side by side with the new variables. We're hoping that that new model will be in use with our members by 2019. So before we move on to the Q&A session, just remind you that you can contact me and us through our website, www.healthroundtable.org. If you are interested in the detailed paper that we have, you can request that. Please just let in the message mention that you attended this IHF forum and are interested in more information. Thanks, Patricia.
Thank you, Rowan. So we'll start reading some questions from the audience shortly. Before that, we have a quick survey, which we will display on the screen now. So if you want to find out more about the Health Roundtable and the model, just choose yes on the screen, and then we'll send the information to the Health Roundtable. So while everyone is answering the survey, just to remind you that you can send your questions by typing them in the questions tab under the GoToWebinar control panel. And then we'll try to go through them in the remaining time that we have. All right. So, okay, so we'll start with a few questions. Rowan, I have here actually a question. So how would someone go about replicating this methodology?
Okay, so that would depend on where you wanted to start from. So if, for example, you wanted to completely replicate it from scratch, certainly our detailed methodology paper should be enough to do that. Alternatively, you know, if you wanted to use the reference tables that we have and sort of start from some point ahead of that, that's also potentially possible. Really, you know, have a conversation with us about where you might want to go with that.
Thank you, Rowan. Another question is, you only talked about in-hospital mortality, but what about post-discharge mortality? Have you also looked at this?
Okay, great question. So of course, post-discharge, you know, mortality, looking at 30-day mortality, that would be, you know, a gold standard to do. Unfortunately, in Australia, it's impossible at this stage due to limitations on data linkage in getting that information, at least from our point of view. Certainly, there are some government agencies that have access to that information, but it tends to be historical information rather than current information. Certainly, there's no reason why this type of model wouldn't apply in exactly the same way using including post-discharge mortality.
Thank you, Rowan. One more question. Is the table of diagnosis risk scores available for others to use?
Yeah, so as I said, you know, we haven't released that at this stage, but we're certainly happy to talk with people if you're interested in obtaining it. We'd have to think about that.
Thank you. There's a question here. What was behind the decision to use 28 days as the threshold between neonates versus PAEDS?
Historically, that's the way the Health Roundtable has defined neonates, and in various parts of the literature, that's how they're defined. So more than happy to take alternative suggestions as we develop those models into the future, but that's certainly been a consistent way of doing that for us.
Thank you, Rowan. Another question, is death the best measure of clinical quality? And what measures do you have about risk of complications or variance of clinical practice?
Yeah, so I think that, one of the reasons it's probably not the best measure, but it's one of the easiest to measure because the outcome's not really in dispute. So, of course, there are many other measures that we could look at. The Health Roundtable does provide a lot of information about complications of care to its members. So in Australia, the Commission on Safety and Quality in Healthcare have released a fairly extensive list of HACs, hospital-acquired complications, and the National Pricing Authority here in Australia is also now implementing funding adjustments based on complications of care. So our members have certainly been very interested in that. We've done a lot of work to replicate those complication of care rates, but yeah, I have no argument with the idea that mortality rates may not be the only or even the best way to measure clinical care. I think it's also important to realize that any models like this, there's always going to be background noise, and at best these kinds of models and these kinds of reporting based on them can at best shine a light in areas where a hospital might be different from its peers, and you certainly can't draw any inferences from it, and you have to be very careful in that regard. But as a light in a dark room, I think it's important.
Thank you, Rowan. Again, everyone, if you have any questions, just type them in the questions tab in your control panel. We have one more question here. Have you graphed actual mortality rates to the 3 models to see accuracy?
I think that's the calibration plot. Is that? I'm not sure what else you would mean. So the calibration plot shows actual versus predicted rate. All
right. One more question is, why is the diagnosis arising during the episode not included in the model?
Okay, so I guess the fundamental point of decision, is that we have to draw the line somewhere. So that the approach that we've always taken is we want to look at the condition the patient was in at admission. Now, granted that some of those things that arise during the episode of care will be natural consequences of the state the patient was in at admission. However, some of them won't be, and we have to draw a line and say, okay, we don't want to include in this predictive model, because of the purpose of the model, right, because we're trying to actually look at variations potentially in care. So we don't want to include things in the model that might be the result of a misadventure in the hospital, for example, or by the decisions that were made around the care of the patient.
Thank you, Rowan. All right, everyone, you can still send in your questions. If there are no more questions, okay. So for those who sent in their questions, thank you very much. If you still have questions, we still have a few minutes left, so you can still send them in. Or you can also contact the Health Roundtable through their website. That's the URL is displayed on the screen. So Rohan, before we close the webinar, is there anything else you want to say or to share to our attendees?
No, just want to thank you again, Patricia, and thanks to IHF.
Thank you, Rohan. So the IHF really appreciates the time that you allotted to share about the Health Roundtable's model. I know that our attendees benefited from your presentation. We'd also like to thank everyone for joining the webinar today. So again, we will be posting the video recording on our website next week. We will send you the link to the recording via email. We hope you can join us again in our future webinars. Next month, we have a webinar which will share a short notice accreditation national pilot in Australia and how it is improving the quality of care. We will send more details about that soon. So thank you again, everyone. Thank you again, Rowan, and I hope you all have a great morning, afternoon, or evening ahead of you. Bye, everyone.